Welcome to this clinical skills lecture on assessing cardiac murmurs. This tutorial expands on the examination already discussed to look at the optimal techniques for locating and appreciating cardiac murmurs. In this tutorial, we're going to cover the following topics: positioning and setup, what are murmurs, diastolic and systolic, locating and appreciating murmurs. We're going to go through the common murmurs, that of aortic stenosis, mitral regurgitation, mitral stenosis and aortic regurgitation, and briefly discuss some of the less common murmurs. As assessment of these aspects will occur during routine examination, the patient should be positioned in the normal way, although movement from this may also be required. Auscultation of certain murmurs is easier in specific positions and by altering the flow with changes in respiration. Murmurs occur when blood flow is turbulent. This can occur when blood is abnormally accelerated through a narrowing, or when it regurgitates against a normal direction of flow. A murmur needs to be assessed according to a number of criteria. We need to look at its location, its duration, the presence of radiation of the sound, and whether it is diastolic or systolic. We will go on to discuss the features of each murmur. However, firstly, a routine examination needs to be considered. Examination of murmurs cannot be performed in isolation. Characterizing the pulse, the blood pressure, and all other parts of the general cardiovascular examination are integral to determining the cause and the severity of a murmur. However, for the purpose of this training video, we will focus upon the auscultation of the murmurs. The patient should be comfortable in the usual position as used for examination. Initially, auscultation should be performed in each of the four primary areas, that being aortic, pulmonary, tricuspid and mitral, and it's often wise, as you can see in the video, to time the sounds heard to the carotid pulse. Dependent upon the findings from these positions, modified locations may also be required. As murmurs radiate, and this can help to characterize them, the clinician needs to go to listen in the axilla and then up into the carotids. Due to the difficulty of appreciating diastolic murmurs, it is then generally recommended for the patient to be rolled to the left and auscultation performed with the bell to hear for mitral stenosis. And then the patient sat forward in forced expiration in order to hear aortic incompetence, most easily heard at the left sternal edge. Aortic stenosis is the easiest murmur to appreciate. It's an ejection systolic murmur that can be often heard throughout the precordium. It radiates up into the carotids and is entirely enclosed within the duration of systole. In the assessment of the severity of the stenosis, the characteristics of palpation of the carotid pulse are absolutely critical. Mitral regurgitation is the other easily recognized systolic murmur. Unlike aortic stenotic murmur, this sound lasts the full duration of systole and in effect extends into the early part of diastole. In the case of the sound, is generally localized to the apex of the heart, although it does also radiate towards the axilla. When the incompetence is caused by the prolapse of one of the valve leaflets, this can direct the murmur more medially, and this needs to be appreciated when auscultating. And prior to the commencement of the murmur, a mid-systolic click can often also be heard. Mitral stenosis is best heard with the patient rolled onto the left side while listening with the bell at the apex, which should be relocated after moving the patient. If the valve is pliable, an opening snap may be heard, which becomes nearer to the second heart sound the more severe the stenosis. A mid-diastolic murmur will be heard, which is rumbling and radiates towards the axilla. If the patient remains in sinus rhythm, there will be an increase in the murmur, called presystolic accentuation, due to the effects of atrial systole. As a result of pulmonary hypertension, consequent upon the mitral stenosis, there may be a loud secondary pulmonary heart sound. Pulmonary regurgitation may be present, and you may even be able to appreciate tricuspid incompetence. Aortic incompetence is also easiest to hear when the patient is moved from the neutral position. In this case, as can be seen by sitting the patient forward in order to increase the left-sided flow, one also adopts forced expiration. The murmur is usually loudest at the left sternal edge. With increasing severity, the murmur shortens and becomes associated with a significant forward flow murmur. In moderate incompetence, the jet interferes with mitral inflow and leads to a diastolic murmur, known as the Austin-Flint murmur, and premature mitral valve closure, both of which are best heard in the mitral region. As well as the murmurs described, it is sometimes possible to appreciate right-sided abnormalities, intracardiac shunts, and extracardiac abnormalities such as coarctation. Although the main features are indicated in the slide here, they will not be covered in detail in this video to maintain the clarity of the main message. I hope you've enjoyed this tutorial and have learnt from it.